Good afternoon and welcome to today's OR Today webinar. Is it really clean? ATP Contamination Monitoring. Today we are joined by Robert Dybec, OR Nurse Manager at NYU Long Island Hospital in New York and consultant to Ruhof. Robert has over 40 years experience in the surgical setting and has been a consultant for several companies providing education to nurses and technicians, both nationally and internationally on a variety of topics. OR Today would like to thank our sponsor, Ruhof. Ruhof is an innovator and leading manufacturer, well renowned for offering reliable solutions and individualized service to help you meet and exceed your decontamination and materials management challenges. For more information, please visit ruhof.com. Just a quick reminder that OR Today is pleased to support the Georgia Council of Perioperative Registered Nurses Annual Conference, which will take place at the end of this month, the 29th and 30th, at the Atlanta Evergreen Lakeside Resort, Stone Mountain in Georgia. Registration is now open, so for more information, please visit gacouncilnurse.org. Today's webinar is eligible for one continuing education hour from the California Board of Registered Nurses. You can obtain your certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1C certificate, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. Okay, let's kick off today's webinar by giving away one of our OR Today live lunch bags to the attendee that can tell me the answer to the following trivia question. September is National Honey Month. Which state is known as the Beehive State? Answer now using the questions feature on your dashboard, and I'll reveal the answer at the end of the webinar. Now, as I mentioned earlier, our presenter today is Robert Dybec. So, Robert, you may begin whenever you're ready.
Thank you, Linda. Thank you very much. You can hear me okay?
Yes, we can.
So, excellent. Thank you. Well, good morning, good afternoon to some. Welcome everyone to this webinar presented by OR Today entitled, Is It Really Clean? ATP Contamination Monitoring. My name is Robert Dybec and I will be your presenter today. And my screen's not changing. Show screen. Linda, my screen's not changing on your end. Any idea?
No, as you have control.
There we go. Now I got it. Okay. Must have just been mine. Perfect. Sorry, everybody. So I first want to thank OR Today for the opportunity to present once again to all of my nursing and healthcare colleagues out there. This is my second webinar with them, and they've been very special. Special thanks also to Ruhof Corporation for their sponsorship of this educational activity. Let me just start by giving you some information on my background. I am currently the OR Nurse Manager at NYU Long Island Hospital, Long Island, which is in New York, which is part of the NYU system, where I oversee 5 surgical specialties. I am also, as Linda described, a consultant to the Ruhof Corporation as an educator, not only for Ruhof staff, but on their behalf at national nursing meetings such as AORN, SGNA, and other professional organizations such as the Central Sterile Processing Meeting. So let's take a look at what we're going to cover today. We're going to explain the history of ATP contamination monitoring in terms of its application to reducing healthcare-acquired infections. We're going to compare ATP monitoring technology to other available methods of evaluating the effectiveness of environmental and medical device cleaning. And we'll describe how ATP contamination monitoring can help standardize cleaning practices in the healthcare setting. So we all know that cleaning is a fundamental principle of preventing infection, and it involves both technical and human components in the healthcare environment. Now, the technical component includes the cleaning of surfaces, water management, air control, waste management, laundering, and medical device, scope, and instrument reprocessing. The human component includes cleaning best practices such as monitoring and verification of these practices. Now, when we speak about healthcare acquired infections, or HAIs, we see that there are many factors that contribute to HAI risk, some of which include patients, low compliance with established cleaning protocols, contaminated surfaces, complex designs of rooms and equipment that can be very challenging to clean. I mean, look at today's operating rooms, how jam-packed they are with complex equipment, wires all over the place, supplies, Da Vinci robots. Are these rooms truly being cleaned or terminally cleaned in an effective manner? Persistent pathogens that are not removed or eradicated through cleaning, and healthcare providers transferring pathogens to patients or other surfaces from improper hand washing. So statistics estimate that pathogens associated with HAIs originating from the patient's own endogenous flora occurs in about 40 to 60% of the cases. From contaminated hands of healthcare providers in about 20 to 40% of the cases, and from contamination of the environment in approximately 20% of the cases. So before we dive deep into ATP, I would like to review some basics. So let's talk about bioburden. What is bioburden? According to ANSI and Amy, bioburden is defined as a population of viable microorganisms on a device or surface. Now, bioburden can result from contamination by blood, tissue, feces, mucus, and can be found on medical and surgical equipment and endoscopes after they have been used on patients in surgical and procedural areas, as well as the surfaces in these surgical and procedural areas. Now, this gross contamination, if left on surfaces or in scopes and instruments for too long, may allow for the formation of biofilm. Now, what is biofilm? Well, biofilm is defined as an aggregate of microbes in which cells adhere to each other and or to a surface, producing a distinct architecture. Biofilm can form as the result of bioburden not being removed quickly and efficiently and allowed to start drying. These microbes will adhere to a surface. They'll begin to build a matrix that holds the biofilm community together, and then the microbes will encase themselves under a protective layer, a protective polysaccharide layer. Nutrients will start to feed the biofilm community and allow them to proliferate and grow. So let's just talk quickly about biofilm risk reduction. So what can we do in the OR to reduce the risk of biofilm? You know, we said that biofilm can form as a result of bioburden development, not being removed quickly and efficiently and allowed to start drying. So this is why we now have policies and procedures in place for the intraoperative care of surgical instruments, wiping instruments intraoperatively to remove gross contamination, post-procedure cleaning of gross contamination, wiping, flushing instruments at the end of the case, and the application of an enzymatic solution or gel to keep instruments from drying out before being received in central sterile for reprocessing. This will reduce the risk of biofilm formation. Good OR practice. So there are 5 distinct stages of biofilm development. Now, stage 1 is the initial attachment. That's where the organisms initially adhere to the surface. Stage 2 is irreversible attachment. That's where the organisms start to protect themselves under that protective polysaccharide layer. Stages 3 and 4 are the first and second stage of maturation. That's where the biofilm continues to grow and mature. And then stage 5, a very interesting stage called the dispersion stage. In the dispersion stage, the biofilm opens up to release more organisms into the environment that will spread and start to colonize new surfaces. Understand also that the bacteria growing inside a biofilm is over 1,000 times more resistant to antibiotics than the same bacteria not growing in a biofilm. Now, this slide depicts the protective nature of the biofilm and how that outer polysaccharide protective layer will not permit antibiotics to penetrate and harm the pathogens growing inside. Some published results of global estimates of deaths associated with 33 clinically significant bacterial pathogens, specifically found that there was an estimated 13.7 million infection-related deaths globally in 2019, with 7.7 million deaths associated with these specific 33 bacterial pathogens that were investigated. So bacterial biofilms are usually pathogenic and can cause persistent and chronic bacterial infections. Among all microbial and chronic infections, to include healthcare-associated infections, 65 and 80% respectively are associated with biofilm formation. These infections are a significant source of morbidity and mortality as the second most prevalent cause of death globally. Now, according to the World Health Organization global estimates, they say that 7 to 10% of patients admitted to hospitals acquire at least one type of healthcare-associated infection. And of these patients, 10% will die. In the United States, approximately 1.7 million patients develop hospital or healthcare-acquired infections annually, with a prevalence rate of about 4.5%, causing more than 90,000 deaths every year. Now, surgical site infections contributed to the highest proportion of HAIs, followed by catheter-associated urinary tract infections. So we mentioned earlier about surgical infections being the most prevalent HAI. Surgical site infections have been associated with pathogenic biofilms and can present 30 to 90 days post-surgery and is the most common post-operative complication. SSIs develop in an estimated 2.6% of all who have surgery and account for 20% of all healthcare-associated infections. So biofilm-associated SSIs are extremely difficult to treat with conventional antibiotics due to the tolerance mechanisms of many of these multi-drug resistant bacteria in a biofilm form. In the hospital, some of these chronic non-healing wounds that we see in hospitals are a result of biofilm, which even after sharp debridement, washouts, antibiotic therapy, they still remain. Now, when you think of the cycles of biofilm development, unless all of the biofilm colonies are eradicated, then they may continue to repopulate the wound when they open up in that fifth stage, that dispersion stage. So regardless of the cause or type of infection, HAIs can have several consequences, including prolonged length of stay, repeat or secondary surgeries, decreased quality of life, increased costs, litigation, and even death. Now, HAIs in U.S. hospitals have direct yearly medical costs of at least $28.4 billion treating these infections. They also account for an added $12.4 billion in cost to society from early deaths, loss of productivity, as well as monies associated with medical legal claims. So let's talk about ATP, adenosine triphosphate. What is ATP? Well, ATP is the universal energy molecule found in all human, animal, plant, bacterial, yeast, and mold cells. This nucleotide is used to transport energy to cells involved in biochemical processes. Again, all living cells will use ATP as the fuel to biological reactions for cell function. It is the energy-derived molecule of the cells first discovered in 1929 by Carl Lohmann and Cyrus Fisk. In 1935, Katashi Makino proposed a structure for the molecule, which you see in the photo on the right there. That's the molecular version of ATP. So, the presence of ATP on medical devices, instruments, or surfaces may be an indicator of residual contamination. We're going to get more into detail about that very shortly. So, in order to understand how ATP testing works, we first need to understand the theory of bioluminescence. Now, bioluminescence is a natural chemical phenomenon that occurs in many living organisms, such as insects, bacteria, fungi, and marine animals, and results in the production of visible light. In nature, bioluminescence is produced by organisms for several reasons, such as interspecies communication, hunting, locating food, attracting prey, and also self-defense. Raphael Dubois was the first to investigate the components required for bioluminescent reactions by studying click beetles. Now, using cold water and the abdomen of the click beetles, he was able to produce luminescence in the laboratory. He named the molecule that was consumed in the reaction as luciferin, and the enzyme responsible for the reaction, luciferase. Now, modern bioluminescence tests are based on the reaction of luciferase extracted from fireflies with its substrate luciferin, known as a luciferin-luciferase reaction. The amount of light emitted in this reaction is directly proportional to the amount of ATP present in the sample. Now, because of its ability to provide real-time results, the ATP bioluminescence method was developed and has been widely used since the 1980s in the food industry to monitor the hygienic status of food production lines and verify the efficacy of cleaning procedures, and now is used widely in healthcare settings around the world. So let's talk about methods of evaluating cleaning practices. So According to AMI standards, tests should be accurate, fast, repeatable, and simple. Assessing successful cleaning processes of surfaces, devices, and instruments, including endoscopes in the healthcare environment, can be supported by implementing contamination monitoring methods, such as direct practice observation, swab cultures, agar slide cultures, and ATP bioluminescence tests. Again, AMI says that any test used to check for cleaning effectiveness needs to be accurate, objective, replicable, rapid, simple, and quantitative. So visual inspection, that can help when gross contamination is visible, but it's not a reliable method in measuring any level of cleanliness. Visual inspection cannot detect biofilm or unseen bioburden. Additional verification is necessary to ensure optimum patient safety, and there are multiple verification methods that can be used as an adjunct to assess cleaning efficiency. So direct observation in and of itself is not a really great method for detecting effectiveness. So you could use, in addition, laboratory cultures, but using laboratory cultures, although easy, and they will provide specific data about which pathogens may be growing, it has time constraints. It's not a quick and efficient test, as we're waiting for days for results to come back. So clearly we can't do laboratory cultures and wait 3 or 4 days for our surgical instruments or our endoscopes to come back to be reused. In these busy healthcare environments, busy ORs, busy endoscopy suites, we need a quick turnover. So laboratory swab cultures, they will tell you if something's growing. They'll even tell you exactly what's growing, but we cannot wait 3 days or longer for results to come back. We need the equipment in a quick and efficient manner. Although some difficulties have been encountered in utilizing agar slide cultures on surfaces that are not flat and broad, the technique generally provides an easy method for quantifying viable surface contamination, but similar to the laboratory swab cultures, it is necessary to wait for results. It is not a time-efficient method. So again, this method will tell you if something's growing, may even tell you what's growing, exactly what's growing, but again, we can't wait for 2 or 3 days for something to start growing in the Petri dish before we can use our scopes or instruments. Now, ATP bioluminescence technique of assessing environmental cleanliness is based on the measurement of levels of ATP present on a surface. It detects organic matter, but cannot detect pathogens that cannot produce ATP, such as viruses. This method is carried out by swabbing a surface, inserting the sample into an ATP test sleeve containing luciferin, which reacts to oxygen, and then placed into a handheld ATP luminometer, where you will get your digital readout, your result of the ATP swab test. So ATP tests will give quantitative results directly proportionate to the amount of ATP present. Following adequate cleaning, ATP levels should be significantly reduced to acceptable levels. Now, the level of ATP contamination is measured in RLUs, or relative light units. ATP testing systems measure all cellular ATP, making them a great tool for knowing the general measure of cleanliness for items being tested. So what are some of the benefits of ATP testing? Well, it is a confirmation of the cleanliness of your surfaces, your instruments, your endoscopes, the environment, whatever you happen to be testing with the ATP device, thereby reducing the risk of cross-contamination between patients. Again, you're checking for your cleanliness. How good a job did we do cleaning? You have the ability to track and monitor cleaning practices. So these devices can be programmed to track and monitor cleaning practices. So for instance, you can use it to check certain endoscopes. You're going to check endoscopes, regularly, and you may start to see some sort of tracing where scope number 3 keeps having some issues with positive or higher than normal levels of ATP. So there may be something wrong with that scope. In endoscopy suites, in central sterile, you can actually monitor devices, instruments cleaned by certain technicians, and maybe like John, Jane, and Joe are all cleaning instruments, but for some reason, John is having higher than normal levels of ATP than the other two. Well, there's some sort of trending going on there, and maybe he needs to be retrained in his cleaning practices or watch to see what he's doing right or wrong. With ATP bioluminescent testing devices, you get a quantitative assessment. So you will get a digital readout of a number, and you can use that for your documentation. Some devices will hook up to computers and you can run reports. If the Joint Commission happens to come in and is looking for documentation on your verification processes of cleaning and cleanliness, you can actually run reports. But more importantly, it's a quick and easy test. So with the ATP testing devices, you will get a measurement in as little as 15 seconds. In 15 seconds, you will get a readout of ATP. Now, understand that anything that you're testing, especially surgical instruments, scopes, things like that, if you have above normal levels of ATP, all that means is that that device or those devices were not cleaned efficiently. They would have to be re-cleaned and retested to get an acceptable level of ATP before you can send them out for subsequent sterilization or high-level disinfection. But again, in 15 seconds, you'll get a readout of the ATP on whatever you're testing. So with ATP and endoscopes, just to mention quickly, we touched on GI and endoscopy suites. When the inner lumen of a surgical instrument or endoscope is cleaned, residual ATP should be reduced to a negligent level. If there's any remaining blood, feces, or bioburden left inside after cleaning, a measurement of ATP above the threshold would indicate a level of contamination. Now, this photo here shows on the right-hand side top picture, that's residual bioburden seen under special fluorescent lighting, which may not normally be seen by the naked eye. Surfaces and inner lumens that test higher than acceptable will again need to be re-cleaned, retested before sending for final sterilization or high-level disinfection. This study compared actually 3 methods of verification using AAMI set criteria. They used ATP, hemoglobin tests, and protein tests. Now, the ATP test achieved the fastest processing time, had the lowest long-term cost, and was the only system that met objectivity criteria. Lastly, the ATP system's ability to test non-critical surfaces, in addition to surgical instruments, shows the system's versatility and potential to impact clinical settings that do not reprocess instruments and equipment. So here's some considerations, and these next couple of slides may actually answer some of the questions that may come in later. But a lot of people do ask, how do we know an item or surface is clean? So again, the higher the amount of ATP, the higher the RLU, the relative light unit. Each device manufacturer who manufactures ATP devices sets their own RLU threshold. Devices by the same manufacturer should be used to create standardization of care. And ultimately, again, with ATP cleaning verification systems, the higher the amount of ATP measured, the higher the RLU value, and any number over that set value would indicate a poor job of cleaning or cleanliness. How frequently should we clean? Well, hospitals, clinics, endoscopy suites should have a comprehensive cleaning and verification protocol, preferably designed by an interdisciplinary team. The team should establish a cleaning schedule for equipment and areas that are not terminally cleaned so that routine cleaning is not missed. This would include other areas, not just clinical areas, but patient waiting areas and procedure rooms, exam rooms, non-critical areas, not just the ORs, not just the endoscopy suites. Well, what should we test? There's no prevailing standard of what should be tested. As would be expected, aside from surgical instruments and devices, contamination of surfaces and objects that are touched frequently creates a risk for hands to acquire pathogens that could be transferred to patients. This supports more frequent disinfection of high-touch surfaces. In one descriptive study, the authors observed 43 surgical procedures and recorded the number of times a surface was touched by unsterile surgical team members' hands during patient care. The most frequently touched surfaces were the anesthesia computer mouse, the OR bed, the nurse computer mouse, the OR door, and the anesthesia cart. Now, using the OR light as a control, this study demonstrated that a low-touch area was less contaminated than the high-touch areas that they noted. So standardizing evidence-based best practices is essential to delivering high-value, efficient care in a safe environment. Quantitative ATP bioluminescence testing can be used to standardize care for perioperative quality monitoring programs, to observe for trends over time, and to monitor performance of cleaning processes and practices, not just in the perioperative environment, but in many healthcare and clinical and non-clinical areas, as we just mentioned. patient waiting areas, restrooms, things like that. Evidence from a published quality improvement project suggests that ATP bioluminescence technology is a quick, effective method to assess cleaning processes and the cleanliness of surfaces, instruments, and devices, which may reduce the risk of surgical site infections. So just to summarize quickly, the importance of cleaning related to infection prevention in the healthcare environment is paramount, and meeting the challenge requires collaboration, focus on evidence-based research, and continual monitoring of our practices. I want to thank everybody for attending. I guess I spoke a little quicker than I thought. I thought this was going to be a little longer, but we're actually going to spend some time opening this up to questions. And if you don't get a chance to have your question answered, please submit them, and I'm told we will get back to you with any answers. So Linda, you're on.
Yep, perfect. Thank you so much, Robert. Our first question is, should we be ATP testing instruments that have been sterilized or endoscopes that went through high-level disinfection?
Should we be testing instruments that have been sterilized? So you can test instruments that have been sterilized or scopes that have gone through high-level disinfection. But these items, they've already gone through their own process of indication. So like for steam instruments, you have steam indicators, high-level disinfection parameters. Those parameters should have been met already. So just not sure what the purpose of testing sterile or HLD items is. You can do it, but I will just say that if you do decide to test these instruments, then they will no longer be considered sterile or high-level disinfection, and you would need to clean them again and re-sterilize them before use on patients. So the fact that you're actually using a swab to test the devices or instruments, then that means you're kind of contaminating it. So you wouldn't want to use it on a patient then. So you will get a readout, but again, not really sure if they've been through the process of sterilization or HLD that you really need to do that. So I hope that answers.
Great. So how do we know what germs may be on our surfaces or instruments with ATP testing?
Well, you won't know exactly what using an ATP test, you won't be able to determine exactly what the pathogens are or the contamination is, like you would with the cultures in the laboratory or the agar slides, things like that. The ATP is only going to tell you that there's something there. There's ATP, which could be a pathogen, which could be harmful to your patient, which might not be harmful to your patient, but the fact that you have a higher than normal level of ATP just means that it could be cleaner before sending it out for sterilization or high-level disinfection or re-cleaning, such as like a surface, like an OR table surface or something like that. Again, a measurement of the effectiveness of your cleaning practices, of how well an item or surface was cleaned. So that's what the ATP test does. It will not tell you you're growing gram-negative bacteria or anything like that. It's just going to tell you whoever cleaned this table, whoever cleaned this scope, whoever cleaned these instruments, didn't do such a great job or missed something. So there's some leftover bioburden there, which may be harmful to your patient. Let's get rid of that, reduce it to a better level of ATP, which will reduce the risk of cross-contamination to other patients.
Great. So what other applications can an ATP test be used on?
Well, I think we pretty much covered most of them. I think, a lot of OR nurses out there were thinking about surgical specialties and the perioperative area. And clearly that's, an area where you can be testing your OR room, your OR table, light handles, even like computer mouses in the room and the keyboards and things like that to make sure they're being cleaned. Other devices that are used from patient to patient, monitors, things that get brought in, video towers, things like that. But other applications, in my particular hospital, at one point, infection control got hold of one of these devices, and they had a grand old time, going around the hospital checking doorknobs going into substerile or dirty workrooms. Hospitality services will use these to check the cleanliness of public bathrooms within the hospital. Central Sterile will use these devices to check their cleaning practices. And many times they'll conduct audits using the ATP and see if there's any trending again, watch for trending, and continually audit, specific areas that they have identified that they want to continue to test, or that they have deemed possibly areas that could pose a risk. So yeah, a couple of other areas, even outside of the hospital, other non-clinical areas, exam rooms in doctors' offices. There's any place you think there could be contamination, you could use the ATP test just to see if cleaning practices have been efficient.
Perfect. So can you explain in more detail the process of testing lumens or channels?
Okay, I will speak to the device that I'm familiar with, but I know there are different devices out there where when you're checking lumens and channels on devices, channels on endoscopes, channels on things like femoral reamers, flexible reamers, things like that. Some devices will have you flush fluid through and test the fluid. The other method is to use a swab, kind of like a cleaning brush that's sterile, to actually go through these channels and lumens, and then you would actually snip the tip off of the swab and put it into your snip the tip off of the brush that goes through the lumen, put it into your swab tester, and then put that into the device. So I view that personally as something maybe a little more accurate than just flushing some fluid through, which might not remove bioburden that's stuck to the sidewalls of a lumen or a channel or something. A brush of the right size would actually like that, whereas it actually possibly be flushing stuff out, bringing stuff out with it as you're pushing it through the channel. So and that's how it's done. It's still the same swab device, but you're taking the tip of this inner lumen brush swab and putting it into the swab test using the same swab test, but you're snipping that piece off. So I hope that clarifies it. I think if you go on to some of the websites there, you'll be able to see exactly maybe videos of how that's done. But yeah, you're actually checking the inner lumens of these scopes.
That's great. Actually, I've had a couple of questions come in about the swab, so I will go to them. Do they have water quality testing swab and surface testing swabs?
Can you repeat that, Linda? You cut out on my end.
Sorry. Do they have water quality testing swabs and surface testing swabs?
I don't know that there's a difference. The main swab, which kind of looks like a big Q-tip, that's used the majority of the time, unless you're checking the inner lumen of a channel or something like that. That swab is what's used the majority of the time to swab a surface. And the swab itself is moistened so that if you're testing a dry surface, say the OR table pad, which has been cleaned and allowed to dry, the moisture on the swab will allow it to pick up anything that may have dried on there. So you're going to get a more accurate reading. I'm not sure that I've never really heard of testing water for ATP. I mean, maybe the companies could address that, but I'm not sure what the purpose would be of testing water for ATP. But I would think if you're going to test water, it would be the same swab. You would just have to dip it in the water and then run it through the test.
Okay, just leading on from that, what would happen if we touch our bare hands in the swab?
Well, interestingly enough, and I'm just going to tell you my experience. Well, if you touch it with your bare hands, the test itself has to be considered negated. You really could not use it. But in the beginning, when ATP first came out many years ago, people were using it to test their hands to see what the quality of their hands were. I just remember being at an AORN meeting, and everybody was coming around and they say, test my hands, and oh, that's disgusting. You have these high levels of ATP, people would go wash their hands and come back, and it would be better. For sure, it would be better. But what we noticed sometimes, though, was like some people were using some hand sanitizers, and they were rubbing their hands like crazy with the hand sanitizer. So what had happened, though, was it wasn't removing some of the cells in there. It was just disrupting them, and actually sometimes making them come up a little more. Like your skin cells were being agitated and moving them by rinsing, but you put them on your hand. So people would come back, and you weren't removing back after using hand sanitizer, and they would actually test even higher than when they came back the last time, because the ATP was detecting these cells. So very interesting. But to answer the question, I don't think it's widely used to test hand hygiene, but I will say again that if you happen to inadvertently touch it with your hands, if you're doing an actual test, then you would have to get a new swab and start all over again. So I hope that answers that.
Okay, just one more. Is the swab sterile? If a device tests for low numbers, will the equipment need re-cleaned?
Start with that again. I'm sorry, I didn't hear the beginning.
Is the swab sterile? If a device tests for low numbers, will the equipment need to be re-cleaned?
So again, each manufacturer of the ATP testing devices is going to tell you what the acceptable number is, and that acceptable number is based on research done independently. So as long as the number is below what they describe to you as the acceptable number, then even if, so for instance, if the acceptable number is 100 or below, 100 RLUs or below, and you're coming up with a number of 65, that's an acceptable number, and it does not have to be recleaned. You're setting the parameter for where the levels of ATP are at a point where it's too high, and that would indicate, the necessity to reclean and then reprocess the instruments or scopes or whatever you happen to be testing. So anything lower than that threshold number is considered acceptable. It will not have to be recleaned. Pretty much you're not always going to get a 0. I've not ever really seen a 0, but I've seen low numbers, 2, 4, 5, 7, 10, 12 on devices, which is a more than acceptable number for ATP.
Okay. Sorry, another swab one here. I'm concerned a swab will contaminate my cleaned equipment. Will the swab contaminate devices?
Again, you cut out right in the beginning of that question, so I'm going to ask you to start one more time.
I'm concerned a swab will contaminate my cleaned equipment. Will the swab contaminate devices?
So it's not that it's going, well, the answer would be yes. If you're going to, I saw one question come through that I think we answered already. It was about, can ATP testing be used in the surgical setting when it's believed that there's bioburden on an item? If you suspect bioburden on an item in the surgical setting, if you're at your sterile field and you're ready to start a case and you suspect that there's bioburden on there, no, you cannot use an ATP test, because then you will contaminate the instrumentation. I mean, our policy should say basically, if you suspect any residual bioburden, if you see leftover blood, if you see bone fragments in a reamer, things like that, that should just be considered not usable. No need to test for ATP. Then you should be sent off the field, and you should get new instrumentation. So if you're using a swab on sterile instruments, you are thereby contaminating them and would not be able to use them on patients.
Okay, so going on to another question, can ATP testing be used in a surgical setting when it's believed that an item has bioburden?
Yeah, that's the question I just answered, basically. So if you're seeing any residual bioburden, if you're visibly seeing something, like I said, bone fragments, blood, something like that, you shouldn't use an ATP testing device. Those instruments should be used. If you just suspect it, you should not be using an ATP testing device, because you will contaminate your instrumentation. If you don't see anything but you suspect it, then again, when in doubt, switch it out. If I was the patient on the table, I'd want you to do what's right. And you have any notion that there could be residual bioburden on something, even though it's not seen, then do what's right for the patient.
Okay, that's great. Can you give an example how often to use ATP monitor when we are using this to determine quality of cleanliness in patient care areas? What type of routine would you use?
Well, those routines have to be set up by the individual organization or the hospital or the department, depending on what areas are being tested. I've always got a lot of questions about, like, how often should we test? Like, for instance, endoscopy suites. Should we be testing every scope every time? Should we be testing every other scope? Once a day, once a week? So again, those are parameters that will be set up by the individual hospital, the individual department. So as far as how often, I mean, if you're checking a patient toilet or a public toilet in a hospital, and you do it, every week for 4 or 5 weeks, and you're getting, acceptable readings, do you really have to? Or if you're checking it every day and you're getting acceptable readings, somebody's cleaning that bathroom, doing a good job. So maybe you switch it off to, once a week, or do random tests. I had one endoscopy suite that said, we don't set up a process of we're going to do every other scope or anything. We do random checks, and they will make sure that the random checks are done on different scopes at different times. So again, set up, and I think we mentioned in the slide presentation, set up an interdisciplinary team to determine what the policy is going to be on what to test, when to test, where to test, things like that. So nothing written in stone as far as those parameters. There's also nothing written yet. Let me just touch basically on, some people ask questions about, well, is ATP testing or some other type of verification mandatory? Well, no organization, the federal government, nobody has said that this is mandatory. It's highly recommended in a number of areas. It's highly recommended by the CDC, by AORN, by SGNA, but nobody has said that you have to do this. But is it a good practice? Absolutely, it's a good practice. Don't you want to know if the people you're relying on to clean your instruments, to clean your patient care areas, to clean your ORs, that they're doing a good job, which again will affect the care of your patient. Subsequently, it will affect the care of your patient. So yeah.
Great, thank you. Another question here. As per your experience, what is the basic RLU for passing the EGD scope?
EGD scopes. Okay, I'm not an endoscopy person, but I have done talks on esophageal gastro, the duodenoscope, the ERCP scope. I wonder if that's what they're talking about with the elevator in it. That was the issue many years ago in California that was determined to be causing cross-contamination to patients. So if you're using an ATP device for testing an EGD scope, ERCP scope, or anything, that you would have to look up the particular manufacturer's number for what the acceptable level of RLUs is. And I don't think they specify what a number is for like any specific scope. They will set a specific threshold number for ATP, period. That's all they're really going to tell you about. I think the big issue is also make sure, especially with endoscopes, the manufacturer's IFUs for cleaning scopes must be adhered to, must be followed meticulously. And it's I don't envy these technicians who have to clean these scopes. When I looked at the IFUs, and there's probably like 25 different steps you have to go through to effectively do this and then test it. And then I can imagine if at the end of all of that, you get a higher than normal level of ATP and having to start it all over again. That would be a pain. But it is necessary to follow the manufacturer's IFUs for the scope itself. ATP testing is an adjunct to what we described. Obviously visual observation. You're going to look to see if there's any residual bioburden. I know that on a lot of these endoscopes now, they have bore scopes. These are tiny little telescopes that can go inside and look for any residual bioburden. Can look for any anomalies that could affect the use of the scope. Leak testing, extremely important to make sure that the scope is solid. But again, as far as ATP, that would be a number set up by the ATP device manufacturer.
Great. Can you give references for how EVS staff may use the ATP?
Environmental services. I can speak specifically to my experience, which is our environmental people who are cleaning our OR rooms. Our AVS people have been trained for cleaning the OR rooms between cases. They do have their managers that oversee and come by once in a while and check their practices. And those are the people who should be checking with an ATP to make sure that all the areas are being covered. So they have a description, job description of how they're supposed to clean, what they're supposed to clean, the chemicals or items they're supposed to be using to clean. And as long as they're doing all of that, then you can literally test any of those areas. I think, though, it would behoove the EVS manager to be in touch with the perioperative people to discuss things like the fact that, oh, by the way, make sure they clean the computer keyboards, things like that we're not always thinking of. So again, describing to the EVS manager the things that we've identified that are high touch items that we need to make sure get cleaned. It's the OR table, that's a given. We know that that's going to be cleaned well. But what about the entire OR table, the base? Any other area where you're reaching underneath to lift the head section up? Did they clean underneath? Now the anesthesiologist is touching that section with their hands and then touching the patient and intubating. So certain areas that could be identified to be tested by the EVS people. But I think a collaboration between EVS and the perioperative team needs to happen. The same way CSPD and periop are very, very in tune with each other and with reprocessing and sterilization. Good question.
I've actually had a request. Could you go back in your presentation to display the objective slide again?
The objectives. I think that was the is it up there, Linda?
Yes.
Okay.
That's fine.
And I'm looking at it, and I believe we did cover all.
Yes, it was just an attendee wanted to see that one again, so I don't know whether you want to leave that up for a while. And we'll move on to another question, unless you want to expand on anything on there. Fine. Okay, that's fine. Another question here.
No, I mean, I did find. Go ahead.
Okay.
Go ahead.
Righty. Let's see. Who can use ATP? EVS, RNs, IPs. How difficult are they to use?
So simple a baby could do it. It is an extremely simple process. Once you're shown the first time and do it, it's an extremely simple device to use. The important aspect of it is going to be making sure that you download software associated with the device. This way you can attach the device at the end of the day or the end of the week and download the test reports. The device can also be programmed, as I said, like you can program it for individuals doing cleaning. You can program it for endoscopes number 1, 2, 3, 4, 5, up to probably 50. You can program it any way you want, and then when you download that information after you've done the testing, weekly, monthly, daily, that's when you can kind of like compare and run reports. So at the end of a month, you've tested 5 endoscopes every day for a whole month. And then you run a report and you say, wow, look at that, endoscope number 4 is always coming back higher than the other 4. So that may indicate that that scope needs to be sent out for evaluation or repair. Again, you're looking for trending. So easy device to use, but very important that you're getting the software in there and also creating it and making sure that you have it set for what you're looking to test. What you want to set up the parameters of what you're looking to test, and that the companies help you run through that and do that, and that's a very, very simple thing to do. EVS uses it, like I said, infection control runs around with these devices, some other areas of the hospital. And it creates a type of audit. You're auditing your cleaning practices, and that's, as I said, if Joint Commission comes in or some of these other organizations, you can run these reports, and it will probably just blow them away that that you're doing this.
Perfect. And another question here is, what is a baseline RLU number as a good surface test? And what is an acceptable number?
I know that we were using the Ruhof product, and I believe that they have their like second or third generation device out now, and I think that based on the research done, the independent research, that the acceptable number is 100. Anything below 100, and you can confirm that by maybe going to the Ruhof site and match. So, and I don't use them personally, but I believe 100 is the number, and we can confirm that if that person wants to just reach out to Ruhof or send a note. We can confirm that. I'm pretty sure the number is 100 or less. I've seen numbers as high as over 10,000. It's just like.
Okay, another
we purposely
question.
wanted to we swab the inside of somebody's mouth, or some definite soil. So and you'll get high numbers.
Okay, perfect. I've got another question here. If an item is cleaned and tested, then re-cleaned and tested, and the item tests higher than the first time, how is that explained? I'm asking because it happened during a teaching moment, and I'm not sure how to explain that.
Wow. Well, I guess that would depend on what the item is and how it was cleaned. I mean, somebody spoke about water testing before, and how do you know if you're using sink water that sink water is okay? Maybe it was something in the water, or maybe some other in the cleaning process. It got recontaminated with something. That's kind of unusual. I mean, even if you do have a high number with a subsequent cleaning, you usually, even though it may be still a high number, you will usually get a lower number. So to go from a high number to a higher number, I've never really heard of that. And I guess there's probably, again, multiple ways that could happen, but not knowing what the device was it a scope? Was it an instrument? Was it, a surface or something like that? Again, it would be a guess. I would just be assuming what it could possibly be.
Okay, another question here is HTP testing more appropriate to use to test environmental surfaces, or for instruments used for invasive procedures or surgical instruments?
Well, ATP for areas like public restrooms and things like that, it's kind of expensive to be running around doing cultures. The laboratory is already overwhelmed with doing blood cultures and other things. They're not going to want to see a culture from the patient toilet on the first floor or something like that. So those tests could be reserved more for again, the high use critical areas, critical devices. But again, with the time constraints involved with that, it's not really practical. The ATP is cheap. It's effective. It's a quick readout. You don't have to be waiting for time constraints to get back. So again, for surgical instruments, that's when you're looking to check the cleanliness of the surgical instruments, that's going to happen after they have been washed and cleaned in central sterile supply. That's when they should be tested, before sending them out for sterilization. So the ATP is just the better bet all the way around for its cost effectiveness and the quick turnover on the results that you get.
Okay, so is ATP the same as Resi testing?
I've never really heard the term Resi testing, so I don't know how to answer that. I will look that up when I'm done, because I've never heard that. I've heard ATP being compared with, we said, hemoglobin tests, protein tests, things like that. I'm not familiar with the term Resi testing, so I can't answer that effectively.
Yeah, we like to challenge you, Robert.
I don't know everything.
We've got time for about one more question, and what is the future of ATP testing?
Well, my thoughts are that, with the amount of litigation, with the amount of surgical site infections still happening, cross-contamination still happening, I feel that eventually somebody is going to come out and say that maybe ATP testing, which, maybe it's ATP, maybe it's some type of testing that we're not even aware of yet, is going to become a mandatory thing. You want to, right now it's a recommendation. It's the best recommendation. It's a great recommendation to reduce the risk of cross-contamination. But I just feel that in the future, somebody's going to say, maybe the federal government or CDC or somebody's going to say, you need to be testing, for cleanliness. You need to be. It's mandatory. You have to do it. So that's the only thing I can see happening in the future. I mean, right now, if you're ahead of the game and you're doing it, great for you. That's putting you on a level that's, much a different level, higher level of taking care of your patients, and again, reducing risk of harm to patients based on cleanliness. So that's the only thing I can think of for the future.
Perfect. Thank you so much, Robert. We're coming up to the end of our hour. So thank you so much, Robert, for your time today and for such a great and informative presentation. I'd like to encourage everyone to visit Ruhof's website, ruhof.com, to learn more about the products they provide to the industry. As promised, the answer to today's trivia question is Utah. So congratulations to our winner, Monica Jacobs. Just a quick reminder, you can obtain your CE certificates by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your certificate, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. Please visit ortodaywebinars.live for more details of all our upcoming webinars and complimentary registration. So thank you for your time again today, and I hope you all enjoy the rest of the day.
Thank you, everybody. Stay safe, and thank you for your service. Bye.
Thanks, Robert.